الإجابة بتاعتها عن طريق الشات إن شاء الله. And this is the first case of a female patient, 73 years old, and she presented by low back pain. And this is the MRI of the lumbar spine, T1 and T2. Then what is your opinion? Okay, no answer. Then I have to answer this, and we have the lesion at L3 vertebral body. The body is almost totally collapsed with abnormal signal, low signal in the T1 and high signal in the T2. And considering the patient age, the most likely diagnosis is a osteoporotic fracture. And you have to say for every patient with osteoporosis having some degree of vertebral collapse, whatever it is, mild or moderate or severe, then you have to say that this is frankly an osteoporotic fracture. And you should know that these osteoporotic fractures are sometimes associated with bone marrow edema, especially if the fracture is recent. And this would not be mistaken for a neoplastic pathology like metastasis, for example, or something like this, because of the residual bone marrow which can be identified in the body of the vertebra. And also you can appreciate absence of vertebral soft tissue components. And this is an osteoporotic fracture. The next case is for the spine, sagittal T2 and sagittal T1. Maybe this T1 is post contrast. Yes, which level of discitis, or this is the previous case, discitis for L5S1 level, and this is as you can see, there is some inflammation of the disc at L5S1 with at this segment or between the sacrum, the first sacrum and the second sacral vertebrae, with some vertebral soft tissue component, and you got some enhancement of the affected vertebral box. The next case is lumbar spine, sagittal T1, sagittal T2, and sagittal T1 post contrast with fat suppression. And these are the provided possibilities. Then you think that this is a meningioma or metastatic deposit or neurofibroma or lymphoma. Yes, and the answer is right. This is the classic appearance of a neurofibroma with an oval-shaped configuration with internal non-enhancing areas of cystic component, and the typical location and typical appearance. This patient is 61 years old with low back pain and also a history of prostatic cancer. This is T1 and this is T2. Then this is sclerotic metastatic deposits. Answer is right. And you got many of the marrow infiltrative lesions that are of black signal in the T1 and T2 weighted images diagnostic of sclerotic or osteoblastic vertebral metastasis. Then the next case is a female patient, 27 years old, with weight loss, headache, and ataxia. Then these are sagittal T1 post contrast of the cervical and the dorsal spine. Yes, the answer is right. These are leptomeningeal enhancement, which appears as nodular lesions intimately adherent to the cord substance, extend along the distance of the spinal cord. Leptomeningeal spread is the appearance of one of four two inflammatory conditions, which are TB and sarcoid, and two which are neoplastic that include lymphoma and metastasis. And based on the clinical data of the patient, or even if you have the images above this level, you can see the tumor in the fourth ventricle, then you may suspect the possibility of metastasis. If not, and you say that this is leptomeningeal spread for differential diagnosis, including so and so. Next case is a female patient, 34 years old, with low back pain. And this is a CT of the lumbar spine. Yes, this is a straightforward case of aneurysmal bone cyst, an expanding lesion of the neural elements of the spine with multiple fluid levels, classic appearance of aneurysmal bone cyst. Next case is an MRI of the spine, and sagittal T1, sagittal T2, and sagittal T1 post contrast.
Recording in progress.
Okay, we can see a lesion in this area at the upper cervical region, and this lesion has destroyed the first and second cervical vertebrae and involved as well the disc spaces in between and associated with pre and retrovertebral soft tissue component that shows the enhancement pattern, and it extends well below the level of the lesion. The involvement of the discs is classic for inflammatory condition, and this is the axial T2 and the axial T1 post contrast with heterogeneous enhancement of the extraosseous soft tissue component diagnostic of TB spondylitis. This is the next case where you can see this is sagittal T1 and this is sagittal T2 with an oval shaped intramedullary cystic lesion in the distal part of the spinal cord, showing low signal in the T1 and high signal in the T2 weighted images. Then ependymoma actually is a solid lesion, but this is a cystic lesion, and there is some of the differential diagnosis for cystic lesions occurring in the spinal cord. Actually, for the diagnosis of epidermoid cyst, you cannot reach the diagnosis without the diffusion weighted images, which will show diffusion restriction in the cyst. These are the possibilities for an intramedullary cystic lesion. Number one is the Chiari malformation due to syringomyelia, Dandy-Walker malformation due to also syringomyelia, diastematomyelia, congenital hydromyelia, or congenital syrinx, I mean, certain skeletal dysplasias, you got cystic changes in the cord, and ependymal cysts, which are similar to simple cysts occurring anywhere in the body. Then post-traumatic, you may got cord injury and syringomyelia. Post-ischemic, you may get also cord ischemia and syringomyelia. Cystic neoplasms like astrocytoma, some types of ependymomas and hemangioblastoma. Also, you may got trapped CSF in cases of arachnoiditis, meningitis, and subarachnoid hemorrhage. The next case is 15 years old male patient with back pain and recent bladder dysfunction. The images are includes the sagittal T1 post contrast and the sagittal T2 and axial T2. And you got, and as you can see here, a classic appearance for an epidural lesion, where you can see that the CSF gets narrower as you approach the site of the lesion with some degree of cord compression. All this supports the diagnosis of epidural pathology. Then the answer of lymphoma is right because of the age of the patient, because the epidural pathology, because of the enhancement of the lesion, because of the absence of associated vertebral pathology. Then these are the differential diagnoses of epidural pathology. The epidural pathology, you got compressed the CSF as you approach the lesion, as well as compression of the cord. Then the differential diagnosis include epidural hematoma, epidural abscess, metastasis, arachnoid, dermoid, epidermoid. All these can occur in the epidural, subdural, and intramedullary spaces, as well as the lymphoma. Then this patient had an MRI, sagittal T2, and axial T2 weighted images. I think the answer is easy. As you can see, the changes in the distal part of the cord. No, this is not arachnoiditis, but you can see it. This is the no, and this is not an ependymoma. This appearance is very classic for vascular malformation. You got some swelling of the conus medullaris associated with increased parenchymal signal, together with serpiginous signal void vessels surrounding the conus. And this is the classic diagnosis of an arteriovenous malformation or dural arteriovenous malformation. The cause of abnormal signal in the conus is either one of two. Either it is due to edema or due to ischemia. And ischemia occurs because of the direct shunting of the blood from the arterial to the venous side without passing to the capillaries. And this will result in some degree of ischemia of the conus medullaris. Then this patient had is a female patient, 20 years old, with quadriparesis. And this is sagittal T1 and this is sagittal T2. I don't know what is papillary ependymoma, but an intramedullary lesion with localized segment may be suggestive of an ependymoma, but you need the help of contrast enhancement in order to assess the enhancement pattern of the lesion, since the ependymoma should enhance. But this lesion, although it's not a classic lesion for MS, but MS is one of the possibilities of an abnormal bright signal in the cord, especially if it is less than 3 vertebral segments. As you know that neuromyelitis optica involves much more substance of the cord and may extend for more than 7 vertebral segments. Then if you see an abnormal signal within the cord and you don't have the post-contrast study, or you have it without enhancement of the lesion, then you think of transverse myelitis or MS, especially if the segment of the cord is short. Then this patient is a male, 24 years old. He is known to have congenital HIV infection as well as TB. Yes, and actually, this is the TB infection, Bot's disease of the spine, of multiple vertebral segments, including the disc in between. Then what's very important is the extensive enhancement inside the spinal canal, and this is what we call TB myelopathy. There is a significant enhancement of the surface of the spinal cord, secondary to a spread of the infection inside the spinal canal. And of course, this is because of the degraded immunity, as the patient is known to have HIV infection. And this is another case of the cervical spine in the T1 and T2 T2 and T1 post contrast axial T2, and there is an intramedullary lesion at let us say C6-7 level. Yes, and because of the short segment and the enhancement, then the ependymoma is the right answer. And if you are lucky enough to look at the T2 weighted images, and if you see low signal hemosiderin along the edge of the tumor, either the proximal edge or the distal end, this can support your diagnosis of ependymoma. The next case is just the sagittal of the dorsolumbar spine, post-contrast, and axial T2 of one of the cervical vertebrae. Then the answer is right. This is neurofibromatosis with extensive intraspinal neurofibromas, markedly evident in the sacral region, affecting most of the sacral nerve roots. And you also got some subcutaneous neurofibromas that are enhancing also with contrast. And in the axial image, you see the classic appearance of neurofibroma extending through the neural foramina. The next case is a female patient, 40 years old, with known breast cancer presented by quadriparesis. This is T2, and this is T1, and this is T1 post contrast. Then the answer is metastasis. This is right because of the positive history of primary malignancy. And this is very important, especially in the sites which are not frequent sites for metastasis. You should have a positive history of primary malignancy, or you see the primary malignancy in the available images. And then if you are asked with what is this lesion should be, and you may say that this may represent an ependymoma because the patient is adult and the lesion is localized. But if you know that the patient had a breast cancer, and you can diagnose at that time the possibility of metastasis. This is the differential diagnosis of intramedullary lesion. On top of these lesions are these two, ependymoma and astrocytoma, which represent more than 90% of the lesions occurring inside the spinal cord. Then comes the lymphoma deposits, cavernous hemangioma, dural arteriovenous fistula, spinal cord infarction, MS Blake's, transverse myelitis, cord abscess, and the post-traumatic cord contusion. This is a female patient, 45 years old, with this lesion in the proximal part of the spinal cord. And this lesion is very bright to represent an MS Blake. This is a cystic lesion in the substance of the cord, which may represent one of two, either an ependymal cyst or a syrinx, localized syrinx. Then if you look carefully and you see the tonsils of the cerebellum are displaced in the upper part of the cervical spinal cord, indicating the Chiari-1, the Chiari type 1 malformation. And you know that with all Chiaris, especially type 2, there may be a syrinx in the spinal cord. This patient is a female child, 10 years old, with an expanding lesion in the spine. And these are the follow-up examinations after receiving a new drug for treatment of such a pathology. Osteoblastoma. Osteoblastoma is an expanding lesion, yes, and it contains some matrix calcification, and this is an aneurysmal bone cyst, and I may remember the name of the drug, but I know that there is a new medication for treatment of aneurysmal bone cyst without embolization, and as you can see, it gives good results. Then the next case is a female patient, 46 years old, presented by increased neck pain during the last 2 weeks, and there is decreased range of neck motion, meaning that the neck became stiff. This is sagittal T1, sagittal T2, sagittal T1 post contrast, and axial T1 post contrast. Spondylodiscitis, right, with a very important lesion that should be mentioned, and this is an epidural abscess. You see the enhancement of the collection anterior to the spinal cord, and this is spondylodiscitis at C5-6 level, with extension inside the spinal canal as well as in the prevertebral area with the formation of epidural abscess. The next case is a case that you can frequently see in the clinical practice. Sometimes you can see that the bone marrow is dark in both T1 and the T2 weighted images. And the darkness is measured according to the signal of the disc. And if the vertebrae in the T1 weighted images are darker than the signal of the intervertebral disc, consider a bone marrow pathology. And you have to go to the T2 weighted images to see if this pathology will increase in signal or persist, as you can see here. And this is the differential diagnosis of the low signal bone marrow in both T1 and T2. Leukemia, chronic anemia, myelofibrosis, sometimes of types of lymphoma, multiple myeloma. Myeloma will show some increase in the signal, and the T2 weighted image also metastasis will do so. And the hematopoietic red marrow or red marrow conversion is not extensive like this. So we are in the upper three possibilities, either leukemia or chronic anemia or myelofibrosis. Red marrow will show intermediate signal in the T1 and is equal or slightly higher than the muscles and gradually converts to fatty marrow during adulthood. And red marrow reconversion due to anemia, obesity, heavy smoking, athletic activity, bone marrow transplantation may show some degree of this. In leukemia, in early phases may appear like the red marrow reconversion. Late phases, the signal in the T1 is lower than the intervertebral discs. Myeloma and the metastasis will show some increased signal in the T2 weighted images, while myelofibrosis will show low signal in all pulse sequences. Then this patient had pneumonia 3 weeks ago. Now presenting by lower limb weakness and bowel incontinence. This is the axial T2, axial T1, and axial T1 post contrast. And because the images may be small for you, and I have magnified this image, which is important for the diagnosis. This is one of the images obtained after contrast injection. Okay, and in arachnoiditis, you know that the nerve roots, beside enhancement, they will adhere to each other or to the inner wall of the cecal sac, forming the pseudocord sign or the empty cecal sac sign. But this patient had just in swelling of the coda equina nerve roots and the significant enhancement, and this is diagnostic of Guillain-Barré syndrome. Enhancement of the nerve roots has these differential diagnoses, and it also included arachnoiditis, leptomeningeal metastasis, neurofibromatosis, but the individual nerve roots are seen within the cecal sac. They are not involved by masses to suspect the possibility of neurofibroma, and this is Guillain-Barré syndrome. This syndrome is an acute inflammatory demyelinating polyradiculopathy. Is This autoimmune may occur after infection, like in this case, or post-vaccination, especially typical like the ADEM, which is acute demyelinating encephalomyelitis, but it affects the coda equina nerve roots and the peripheral nerve roots as well as the cranial nerve roots. 70% are antecedent, meaning secondary to a viral infection, and usually presents with ascending type of paralysis and sometimes with respiratory paralysis. In the imaging, you got a smooth enhancement of the coda equina and maybe the conus. The nerve roots may be slightly enlarged, but they are not amalgamated with each other. And some of the nerve roots may enhance much more than the others, and this is the treatment plasma exchange or intravenous administration of immunoglobulins. This case is a male patient, 67 years old, presented by progressive upper and lower limb weakness. Sagittal T2 and sagittal T1 both contrast show an extensive lesion in the spinal cord. Yes, astrocytoma is a good possibility, although the age is not helpful in the diagnosis. But you know that astrocytoma, the tumor of the pediatric age group, it can also affect the any age. As you can see here in this particular case, you got an extensive lesion involving the cervical cord and the part of the upper dorsal cord with some enhancement and cystic changes within the tumor. The next case is a male, 33 years old, with persistent low back pain after lumbar spine surgery. And the persistence of symptoms after surgery is known as failed back syndrome. And this failed back syndrome has many causes, including postoperative complications, as well as disc recurrence, disc infection, and arachnoiditis. Then, what do you think the complication in this case? Okay, the recurrent disc herniation, good. And this is right. You see in the axial images. This is the T1 pre-contrast, T2 and T1 post-contrast, and you got significant enhancement in the epidural scarring as well as the residual part of the disc, and this is known as failed back syndrome. And here are the causes. Number one, postoperative hemorrhage or infection or dural tear with formation of pseudomeningocele, sequestrated disc fragment, or hardware, the nails or the plates and the screws are malpositioned, and the surgery at a wrong level. And this is also one of the possibilities that you operate at a wrong level. The disc is at L5S1, then you operate at L45, for example. And these are the late causes of failed back surgery, like foraminal or canal stenosis, instability due to surgery, of course, recurrent disc herniation, epidural fibrosis, and arachnoiditis. And this is an example of failed back surgery syndrome where you got evidence of laminar fenestration on the left side with recurrent disc herniation surrounded by enhancing granulation tissue. This patient is a male patient, 25 years old, with progressive lower limb weakness and sensory disturbance. Then you got in the T2 weighted image extensive expansion in the spinal cord. And in the post contrast image, you got multiple lesions. This is one, and another one, and a bigger one in the lower part. Then what do you think? MS? No. This is not MS. If you look carefully for this T2 weighted image, and you can see some signal void patent vessels in the larger lesion, and this may lead you to suspect that this is hemangioblastoma. And if you see multiple lesions, then you should uh, you should consider that hemangioblastoma can occur in multiplicity in patients with von Hippel-Lindau syndrome. And you may say that I cannot see a cystic lesion or a cystic component around the solid component, and this occurs frequently in the spinal cord. Then multiple metastases within the spinal cord is, yeah, let us say, a rare possibility, especially in this age, and you do not have a positive history of the presence of primary malignancy. Then the cord is an odd site for metastasis, and you are not allowed to diagnose metastasis in the spinal cord unless you have a positive history of malignancy. This case is a 48 years old female with a known breast cancer, developed rapidly progressive lower limb weakness, and you got a lesion in the distal part of the spinal cord. And actually, the von Hippel-Lindau syndrome is a good answer for the previous case. Then what about the current case? You got a positive history of malignancy and a lesion in the spinal cord. The answer is easy, and this is metastatic deposit in the spinal cord. Then this patient is a male child, 12 years old, and he got surgery at the age of 2 years with spinal cord excision of a lipomeningeal. The sagittal T1 and the T2 showed. Yes, and there is a lipoma, but what's more important is the cord tethering. The cord is seen extending low down to the level of S2 sacral segment, and is surrounded by fatty tissue, which is of high signal in the T1, relatively low signal in the T2, and is not continuous with the subcutaneous fat. And this is tethered cord with an intradural lipome. The next case is a straightforward case of some anomalies in the spine. What do you mean by type 2? Yes, diastematomyelia. There are multiple block vertebrae. Many of the vertebral bodies are fused together, and there is separation of the cord over a segment into two halves, and these halves are separated by a bony bar at some level, and they appear to be in the same cecal sac at the upper level. Then the diagnosis is diastematomyelia with anomalous vertebrae in the form of block vertebrae. Here you got a lesion in the spinal cord, and this lesion at the age of 1 month was like this. At the age of 9 months, sagittal T1 and the T2 weighted images, and this is the fusion weighted images. Okay, epidermoid cyst is the right answer. And actually, if you look carefully and you see a dermal sinus, and this sinus connects to the skin to the inside the spinal canal. The dermal sinus may be associated with many of the dystrophic abnormalities. One of these abnormalities is the formation of a cystic lesion either in the epidural space, in the subdural space, or inside the substance of the cord. And this lesion may represent a dermoid or a epidermoid cyst. And whenever you got diffusion restriction and you think of an epidermoid cyst with the dermal sinus association, I mean. Then this patient had metastatic ovarian adenocarcinoma, and and presented by, okay, that's the right answer. Presented to the emergency room with progressive lower limb extremity weakness and intermittent urinary retention. Then you may assume, because of the history, that this may represent metastatic deposits, and this is right. And now there are two signs reported in the literature for supporting the diagnosis of metastasis. The first sign is known as the RIM sign. If you look carefully at the lesion after contrast enhancement, and you do not see that the lesion is homogeneously enhanced, but it appears like it is surrounded by a rim of more enhancement compared to the original tumor tissue. This is known.
انا فاهم قصدك بس هو صح مش فاهم بس هو بس
This
اصلا
is known.
العمليه كانت المدرسه بتاعت الكورس ما كانتش
Okay, please, can you stop talking in order to not to disrupt the recording? Okay,
بنحاول
can you,
نتطور معاهم هم
please,
دخلوا في الكورس.
Dr. Sharif, you may block the
هقول لك
microphones.
انا جبتها ساعه الكورس الاول لغايه دلوقتي في مشاكل معاه فيها عشان انا كنت
Okay, and this is the what we call the rim sign, and the other sign is known as the flame sign. And in the post contrast image as well, you got what looks like a flame at the proximal or the distal end of the tumor. These two signs, the rim sign and the flame sign, are some of the recently reported signs for the diagnosis of spinal cord metastasis, especially if you are not supported by adequate clinical data about the patient. Then the next case is a female patient, 62 years old, with recent paresthesia of the lower leg and a cutaneous defect that has been closed in early childhood. And what do you think about this lesion? Okay, actually, and here also you see the dermal sinus, and you got a small meningeal sac with extension of the neural elements through the spina bifida into the meningeal sac, which is diagnostic of meningio myelocele, but it looks very small compared to the lesions that we usually see in the clinical practice. This male patient, okay, the answer is right. This male patient, 49 years old, with a new diagnosis of lymphocytic leukemia, presented by intermittent burning back pain, leg weakness, and loss of deep tendon reflexes. This is the initial MRI, and this is the follow-up MRI of the same case, I think 9 months later or something like this. No, this is not metastasis. And actually, if you look carefully and you see the, let us say, the Chinese figures that are seen in the long bones infarctions. And this is also an infarction, multiple vertebral infarctions showing the appearance of what looks like the Chinese figures. And of course, because of the ischemic changes in the vertebrae, they may show some collapse, and this will collapse may be associated with some change in the signal appearance. And this is multiple bone infarctions that occur in the spine as similar to the long bones. Then this is a child with T1, T2, and T1 post contrast, and you got an extensive lesion in the spinal cord. Astrocytoma is a good answer, and this is, let us say, an almost classic appearance of a long lesion with a cystic component and solid component affecting a long segment of the spinal cord. This 9 years old child with sagittal T2 for the brain and sagittal T1 post contrast for the whole spinal cord. And tuberculoma in the cord, I advise you don't diagnose this possibility because it's considered extremely rare. Tuberculomas in the spinal cord are considered extremely rare. But if you look carefully, you may see a tumor in the fourth ventricle, and at this age you may think of an ependymoma, and the ependymoma may show CSF seeding or CSF drop metastasis along the ependymal lining of the spinal cord, and this is was a medulloblastoma with leptomeningeal metastatic deposits. Whatever the lesion is an ependymoma or medulloblastoma because it involves part of the cerebellum, but both can induce this extensive leptomeningeal metastasis. This is another case of MRI cervical spine T1, T2, and T1 post contrast. Yes, the answer is right. This is an intramedullary cavernoma, and you got hemosiderin inside the lesion as well as along the whole periphery of the lesion with faint post-contrast enhancement. This is a classic appearance of an intramedullary cavernoma. Thank you.